All right. Hello to everyone. And once again, it's really great to be introducing Dr. Norbert Gleicher, Center of Human Reproduction, who's been an icon, I think, in the community of innovative fertility care and a lot in the way of looking at out of the box things and also exploring the why of things. And so we're going to talk about add-ons, I think, today, which we're seeing so much in fertility. Um, how are you today, Dr. Gleicher?
I'm good, but I'm not sure how much I like to be an icon, but I guess it could be worse.
Well, it's
it,
certainly someone we've
means
always looked
old.
up to.
It means old, you know.
Well,
Anyway,
I think experienced and I don't think you're age wise. I think you're still working in the space means you're young. I don't think age matters in my opinion.
uh, up
So
to a certain point. But anyway,
yeah. So
add-ons, add-ons. So
what do you think?
we're drowning in add-ons. Yeah. Our British colleagues coined this term a number of years back for everything that has been added over the last 10, 15 years to standard IVF practice. And it's obviously a very long list. And it has changed IVF practice dramatically. And in my opinion, not always to the better. That's probably the most general statement that I can make. Do you want to talk about any particular add-ons?
Well, we know that there are diagnostic testing add-ons, there are therapeutic add-ons, and I know in our practice we offer many add-ons, and a lot of that has been, I think, mostly due to the fact that people are looking for something that hasn't worked in the past and something new and different. Yeah. And obviously, the science doesn't always answer the questions about which works and which doesn't work. If it's costly and it's obviously not beneficial, is one thing. But if it's less expensive and may have some benefit individually, what are your thoughts on that?
Yeah, I agree in principle with that. And this is actually a very important point that is often missed in the discussion. There's a big difference in, let's say, prescribing vitamin D that costs 5 cents per day, or ordering on everybody PGTA, pre-implantation genetic testing, which is probably nowadays the most popular add-on in IVF, which adds $5,000 to an already expensive IVF cycle.
Mm-hmm, mm-hmm,
I think the consideration should be different. I totally agree with you on that.
Well, I in general don't recommend the embryo biopsy testing because not only is the cost of the test, but then it's and the biopsy, the freezing, and then a frozen embryo transfer, which adds a tremendous amount. Yeah. Plus the idea that many of these diagnostic tests on embryos may not be accurate.
Absolutely. I couldn't agree more. I couldn't agree more. And we at the CHR, we have been speaking out against chromosomal testing of embryos really since 2007, 2008, when we published our first paper on the subject. I totally agree. Yet, on the other hand, it is, as I said, the most popular add-on to IVF in an increasing number of IVF centers. It's almost being mandated. They will refuse doing an IVF cycle unless you agree to PGTA. And I find that personally astonishing, but that's what it is. And when you look
are we losing embryos? I'm sorry, go ahead.
Yeah, no, we are losing embryos. But before we get there, what I wanted to say is that even though there is, over the many years that I had a personal interest in the PGTA issue, previously called PGS, if you remember, pre-implantation genetic screening, the evidence that it doesn't work, meaning it doesn't improve pregnancy and live birth rates, it doesn't reduce miscarriage rates. The evidence now is so strong that even proponents of the procedure have a hard time arguing for it. And yet still the utilization is increasing. And there's something wrong in our system when that is happening. So that is really bothering me. Now, there is a lot happening to embryos when you do that. The biopsy, the false positive diagnosis, which are probably the biggest problem of them all. The fact that we now know that embryos can self-correct, even if they are, showing some chromosomal abnormalities. So the more we know, the more evidence is there that it doesn't work, and still it is being used more and more.
What do you think people are looking for in the fact that they're using it so much? Is it the science that's selling the concept that it's valuable, or is it the belief in the science so much that we're unwilling to look at the side of the failure of science?
That's again a good question. Are you referring to what? Are you referring to the patient, or are you referring to our colleagues who use it very actively?
Well, it's interesting because even the patients seem to be asking for it more and more, because they believe in the science of what we do so much, and believing the accuracy of a test on an embryo, and to err on the side that you're putting in an abnormal embryo is worse.
Yeah, I think you're right, and patients read more. Unfortunately, the information they're getting and where their conclusions are coming from is incorrect. They still get most of the information from our colleagues, and much of that information, I hear that from patients every single day, comes from colleagues. Now, and there's the internet, and there's the friend, and who had fertility treatments, etc., etc. That obviously all plays into it. But all of that is not only relating to chromosomal testing of embryos. It's the same story with the implantation window testing, the ARA testing that became another fashion of the moment, and does not cost $5,000. Okay, but there too, there is considerable pressure from patients to test because somebody told them it works. Now, that there have been by now half a dozen studies to show that it doesn't work, amongst them a fantastic prospectively randomized study from our colleagues in the Netherlands not too long ago. I'm sorry, from our colleagues here on the East Coast, in the Washington area. But still, the patient asks for it. So then it is, I think, our responsibility to try to inform them. And we don't always succeed because we don't do, for example, a lot of PGTA, and we are not doing ARAs. But sometimes we do them because the patient simply wants it. Yeah.
But in the case of genetic disorders, cystic fibrosis or X-linked disorders, there seems to be some value there, do you think?
Absolutely. That is a completely different story. That's a very accurate test. I'm not against testing. I'm very much in favor of testing if you get reliable information. The problem is when you test an embryo and when in 40% what you think the information is that you get is incorrect. That is, in my opinion, an unacceptable false positive rate, and I cannot accept the argument that is always thrown at me. Every test has errors. That's true, but it is 0.5%, 2%, 1%. It's not 40%.
So we've got some questions in the group already. May I go ahead and just kind of put Nancy Staley Jaquez said she was a patient of yours in 2014. And Anna Landis, please discuss embryo testing for older females. So really age doesn't matter when it comes to the aneuploidy testing or euploidy testing for any age.
Yeah, that is in principle true. I think you're right. Even though once again, that is not what the genetic testing industry is promoting. They are making the argument that aneuploidies increase as women get older, and therefore they want to make the argument there's more rationale for testing in older women. What they are forgetting and what they're not telling the patient is that older women are producing fewer eggs and fewer embryos. That if you have a false positive rate and you throw out or do not use embryos for all the wrong reasons, if you just throw out 2, it may be half or 2/3 of that patient's total pregnancy chance because she may have only 4 embryos. On the other hand, in a 25-year-old with tubal infertility, you may be sitting on 15 embryos, and if you lose 2, not a big deal, right? So everything is relative, and therefore I cannot accept the fact that this is more indicated in older patients. So I would argue the opposite.
So we're talking about add-ons for IVF today with Dr. Norbert Gleicher from Center of Human Reproduction. So would you say that the issue with the testing is that it's the information that's gathered is incorrect, or the embryo is able to correct itself or remove the abnormal cells from the actual fetal tissue?
It is, both is true. And we have no way of knowing. The only thing that we do know, and we at the CHR know this since 2014-15, and actually collaborated with your friend Andrea Vidali and some other colleagues in the early days on this, when we were the first ones to start transferring so-called chromosomally abnormal embryos, and had, as we expected, but to the shock and surprise of many of our colleagues, and had healthy babies. Yeah. Because up to that point, the general knowledge or the general assumption was you put in an aneuploid embryo, you get an abnormal baby. We didn't believe so, otherwise we obviously wouldn't have started doing it. And luckily it turned out we have been right, and we have been transferring selectively abnormal embryos for that reason since 2014. And we just published our a series of 50 consecutive cases with really very surprising pregnancy rates and live birth rates for the kind of population.
I have to imagine that if we're transferring a significant number of untested embryos, we should be then seeing a certain number of abnormalities, if that's the concern with a tested embryo, but it doesn't seem like we are. So there should be really little fear in transferring those embryos.
My colleague, Dr. Barad, always says if those arguments that the genetic testing industry throws at us are correct, we really have to introduce legislation to prohibit sex in your bedroom, and everybody should have PGTA. Because what's the difference, right? I mean, it's an almost bizarre argument when you think about it. But to come back to your question, both is true. The test can be incorrect, and because many embryos self-correct in what's called the embryonic cell lineage, which is the cell lineage in an embryo that makes the fetus, makes the embryo. Because of that self-correction, you can have actually a correct diagnosis in the biopsy, and it is still a false positive because the embryo downstream will correct itself to a significant degree. Not in the placenta. That is the genius of nature.
And I think at ASRM last year, there was a great video presentation that showed the abnormal cells being pushed out to the trophectoderm or the placental environment, which shows a mechanism of self-correcting.
Yeah. There's no question. It was first shown now 7-8 years ago by British investigators in Cambridge in the mouse, and they even titrated the amount of aneuploidy in the fetus, and they showed that up to 50%. If up to 50% of cells were chromosomal abnormal, the embryo could still self-correct in a high percentage of cases. And we, in collaboration with colleagues at Rockefeller, a year and a half, 2 years ago now, showed the same self-correction for the first time in human embryos. And again, it's a process that happens very quickly. It takes maybe 72 hours, 3-4 days, and the aneuploidy rate that at blastocyst stage is roughly 80%, 80+%, drops into the single digits. It's really amazing.
So what are your thoughts on day 3 versus cleavage versus blast transfers? There's a question here on that, and from Christine Snow. Would you comment on that for us?
I love to, because that is another very important issue where I frankly don't understand. I don't know if the questioner is aware of it, but ASRM in its most recent guidelines considered blastocyst stage transfers the routine IVF way of culturing embryos. I think that is ludicrous, to be very honest, because again, first of all, as I always say to students and anybody else who wants to listen, whenever you learn in medicine that you should do something to everybody, that's when you need to start getting concerned. But aside of that, it is also a classical example for an error that we make in reproductive medicine over and over. We test something in a very selected patient population. And in this case, It was obviously the Colorado group with Gardner at the helm in the laboratory, who were the first ones to report on alleged improved pregnancy rates with blastocyst stage cultures. And they did their testing in a very selected patient population, young, healthy women, and they got great pregnancy rates. Not a single study that tried to repeat their study in unselected patients has ever been able to demonstrate an advantage, an outcome advantage of blastocyst stage embryo culture. Very much to the contrary. There are, don't know the exact number, but I would say there are at least 3 or 4 very good prospectively randomized studies of day 3 and blastocyst stage culture. All have shown no difference in cumulative pregnancy chance for the embryo cohort of 1 cycle. And if there's no cumulative pregnancy chance, what's the purpose? I mean, getting that patient pregnant 1 month earlier? Is that the reason really to do blastocyst on everything? And then we are coming back to the same issue we discussed before with PGTA, that if you take embryos to blastocyst stage in your older patients, you're going to lose most of them. Mm-hmm. Because their embryos, even in good embryology labs, they rarely make it to blastocyst stage. So we are also strongly opposed to blastocyst for everybody, since we have a very adversely selected patient population in general. It's actually a minority of patients here at the CHR who have blastocyst stage culture. Most have cleavage stage culture.
And would that be the day 3 cleavage that you're mostly culturing to? And And let's see. So someone brought up, Tamara, about testing for gender, which is a little bit different. But we've had cases of gender being correct, and it turned out that the test was not accurate.
Yeah, I must say, fortunately, we have not had that happening. But I think maybe your friend Andrea Vidali told you that in the very early days, when we started to transfer so-called abnormal embryos selectively, we also did a study where we tricked one of the prominent laboratories to a minor degree. Mm-hmm. And we tricked them by really taking some embryos that were donated for research and cut them into little pieces and sent them in as PGTA biopsies into the lab. And so the laboratory got different biopsies from the same embryo. And then we looked at the results, and we got what we expected, in that the biopsies from different sides of the same embryo had sometimes different results. That's what you would expect from mosaic embryos. But what surprised us, that we got sex differences. That we had 1 or 2 cases where biopsies from the same embryo gave us a female as well as a male result. Okay, so those were the earlier days of PGTA testing, and maybe in those days there were also some technical difficulties. But it was obviously very telling that you are
Mhm.
sending to the same laboratory biopsies from the same embryos from different locations. And one time you get back that it's a female, and the next time you're getting back it is a male.
Well, today I did a laparoscopy on a young lady who's she's had miscarriages post a transfer of donor egg embryos. And she had a test of the Receptiva DX that said she did not have endometriosis. And yet, our laparoscopy today, after 3 miscarriages on donor egg embryos, noted a moderate amount of endometriosis.
Doesn't surprise me again, because again, it's one of those tests. It's like the receptivity test, that a whole company was built around that test, a worldwide company, and it's worthless. And the problem is not so much the test or the tests that turn out not to do what they want. I think the problem is a bigger problem that we have in our specialty, and maybe beyond that in medicine in general. And that is the problem that we have with so-called laboratory developed tests. Yeah. Laboratory developed tests, the concept happened a few decades ago when country doctors had their own little laboratories in their country offices, and the FDA didn't want to inspect them and test them, and so the FDA excluded the concept of laboratory developed tests from inspection by the FDA. But what has happened is that a lot of smart people took advantage of that, and those were not necessarily the country doctors anymore. And today, PGTA is a laboratory-developed test. The FDA has not reviewed it. The laboratory that does PGTA testing is not being reviewed by the FDA. Yeah,
Very interesting.
It's bizarre.
Very interesting.
It's bizarre.
It is. Oh, can I throw in a couple more questions here? Laura has, do you still believe in taking an older woman's eggs out early, 16 millimeters, doing a retrieval and triggering them when the leading follicles hit the 16 millimeter range? That would be a good question.
Okay, that is indeed a good question, and I'm actually pretty surprised that Ms. has asked this question, because very few people know about that. Yeah, we have been now for 7 or 8 years taking eggs out earlier in older women, and the older they are, the earlier we are taking eggs out. And that means that in women above age 45, we may trigger them as small as 11 to 12 millimeter. And the oldest patient who had a baby with her own eggs at our center, and who, according to the literature, is probably also the oldest patient elsewhere having a baby through IVF. She was 48 when she went through IVF, and just 48, and deep into her 49th when she had her baby. She was triggered at 12 millimeter lead follicle cells. So this is routine today in our center. We call it here highly individualized egg retrieval, and it is a core component of how we manage older women. Yeah.
Do you think it's what is it about triggering so early, do you think, that helps get those better quality eggs and ultimately a better quality embryo?
Good question. And that's actually how all of this started. About 7 or 8 years ago, we tried to figure out why in our older patients we see, as the literature shows, a slow decline in pregnancy and live birth rates as they get as they get older, over age 40. But after age 43, that slow decline turns into a waterfall. And we tried to figure out why. What happens at roughly age 43 that suddenly results in this significant decline in outcomes. And so we did a molecular study of the environment of follicles in women at different ages. And what we discovered is that premature luteinization or luteinization of follicles that in younger women usually do not happen before 22, 23 millimeters lead follicle size is happening earlier and earlier as women get older.
Mm-hmm.
And once a follicle is luteinized, as you know, you can throw out the egg.
Right.
And since we couldn't stop, we didn't find a way or couldn't figure out the way to stop this luteinization. We said, okay, then we have to get the eggs out earlier. And that's how the idea started. And we started at 16 millimeters, as the questioner asked, in the early days. But we very quickly discovered what I said before, that the older the patient is, the earlier we have to go. And today, retrievals or triggers at 11, 12 millimeters are routine. We rarely, again, because of our patient population, which is so much older than elsewhere, we rarely today take patients to the usual 18 to 22 millimeters.
And what do you think the value is in the younger patient, in the 30s?
That's another good question, because the same thing actually happens in younger patients who have premature ovarian aging. So there too, we go much, much earlier. It's just a little harder to find the starting point. If we go just by age, we are saying, okay, 43 is 16 millimeters, 45 is 12 millimeters. But what do you do with a 28-year-old who has an FSH of 35?
Mm-hmm. Mm-hmm.
You know, there it is harder to find the starting point. Once you have done one IVF cycle and you see how the eggs are, we adjust, and then it is pretty much the same thing. But that first cycle is harder to judge in a younger patient.
Well, we're talking about add-ons with Dr. Norbert Gleicher from Center for Human Reproduction. Regina Marie is bringing on a question about platelet-rich plasma. And I know this is another add-on that some people offer. And what are your thoughts on this for ovarian rejuvenation or even intrauterine in some cases?
Yeah. So this is absolutely an add-on that is widely used. Was first reported out of Greece by some colleagues in Greece who reported that this platelet-rich plasma, PRP stands for platelet-rich plasma, injected into the ovaries supposedly gave them some pregnancies in women with primary ovarian insufficiency. The problem with the paper, which were just, I don't remember the exact number, maybe 8, 10, 12 cases at the most, the problem was that most of their patients were really not what we call primary ovarian insufficiency patients, but what the European, the ESHRE guidelines call primary ovarian insufficiency. In the US, the diagnosis of primary ovarian insufficiency or early menopause is usually describing an FSH over 40. In Europe, it describes an FSH over 20. And so most of those patients were between 20 and 40, which is what we call early ovarian aging or occult primary ovarian insufficiency, but not early menopause. So that was the first problem. But everybody, as usually in infertility, everybody jumped at it. And so, as you correctly said, a lot of IVF centers are doing it. And some of them created that name ovarian rejuvenation, and I have no idea where that's coming from, but that's very frequently indeed used. Because we did not want to do it that way, we started a clinical trial. And we first started a clinical trial for truly women in premature ovarian failure with primary ovarian insufficiency, under age 40, FSH above 40. And as we started that trial, a lot of our older patients were very upset that they couldn't participate because they were older, above age 40. And so we started a second trial in women above age 40 who had, as an entry criteria, had to have a failed IVF cycle with at most 2 eggs. And both of those trials are still running. The first one is almost complete. I think we are missing another 4 or 5 patients. The second one, we had a preliminary report already published, which suggests that in some patients you do get benefit out of the procedure in terms of egg numbers. Pregnancy rates, we don't have enough cases yet to make a statement whether it does or doesn't. And what that study also in the preliminary report showed is that obviously, as one would expect, the younger the patient is, the better her chances are that it may work and it may help. But we also started in the meanwhile a third trial, we call it PRP3, which is in many ways probably the most important one because it is a strict prospectively randomized study where we compare the PRP fraction of the patient's blood against another fraction of her blood. And this study is important because even assuming that the final verdict is that PRP does work, the question becomes, is it really the PRP that is working, or is it the needling, the mechanical destruction of tissue, which also is known to induce certain activations of dormant follicles? I mean, we know that from ovarian tissue transplants, when you implant them, you have a huge recruitment happening right away. So that third PRP trial that is still going on is hopefully going to give us the answer for that question. So we do a lot of PRP, but we do it in principle as trials because we consider it an experimental treatment. We do not, like many other centers, just do it. And we follow the patients afterwards very closely. We keep the records that are required for a trial. So it's a little different.
So there's interest in trying to identify the value and answering some questions the way you're proceeding with this. But some people may get it that don't fall into the study, but you're still following those to see if there's value.
Yes, we do.
Okay,
yes.
Good.
Yes, and we do not have yet a trial for PRP use in the uterus. You raised that too. Some people do that. We have done a few sporadic patients where GCSF hasn't worked in getting thickness, but I don't have enough data to make any comments. But it is, again, it's pretty widely used in a lot of IVF centers.
Hold on one second. I'm gonna put up a question because I got the gardeners outside suddenly. Sorry about that. It's one of the beauties of being in near the garden. Let's see. Nikki asked a question about immune issues, all the additional labs to what a reproductive immunologist would perform, or do you recommend going through reproductive immunologist and have a more personalized treatment plan? So the question is looking for immune issues, and you need all the testing. And what treatments, if any, may be valuable in the immune side? What are your thoughts on that?
That's a very controversial issue, as you know. And I can only tell you what our thinking is without making any claims of being smarter or better than others who do things differently. And there are big differences between people who deal with immunology. I mean, there are colleagues who still to this day believe that immunology doesn't play any role in infertility. Some very prominent fertility centers here in New York City, for example, have hold this position. I think, again, that is pretty ludicrous for one simple reason. Pregnancy is an allograft. It's tolerated against all rules of immunology. And it is probably, at least that's how I understand it, tolerated because a healthy female immune system, once it gets certain messages from an embryo that the embryo wants to implant, has the ability to reprogram itself. The immune system induces what is called in immunological language tolerance pathways. Not only a pregnancy does that, parasites do that. Bacteria in our bowels do that. That's why we have pounds of bacteria in our GI tract, and the immune system tolerates them. Cancer does it to our detriment. Okay? So the induction of tolerance pathways is essential for tolerance against whatever it may be. If a woman's immune system loses the ability to correctly induce those tolerance pathways, that's when we get into trouble. That's when implantation may get harder. That's definitely when miscarriages happen. I'm careful in my wording here because whether immunology affects implantation in that sense is less well established than the link to miscarriages, which is pretty clear. So if a woman is a repeat aborter or has an implantation problem, she may have difficulty inducing those required tolerance pathways. And who are the women who have this problem? Women who have a so-called hyperactive immune system. Women who have evidence of autoimmunity. You don't have to have an autoimmune disease, but having autoimmunity just by laboratory findings. Those are women who have inflammation. Again, you don't have to have inflammatory bowel disease. Endometriosis is an inflammatory disease, for example. Thyroid is an autoimmune disease and to some degree inflammatory. Even patients who are just sometimes very hyperallergic. I'm sure you have, you see like we do, women who are allergic to everything, you know. Even that. Women who have a hyperactive immune system don't induce tolerance pathways well. And I'm giving you this long answer because I'm really trying to answer the question of this listener, what our testing should be. There are some people who believe you have to test the whole immune system. We don't. We believe we need some selective tests to determine whether a patient has a hyperactive immune system or not. It doesn't matter to me what tells me whether she has a hyperactive immune system or not. If she has a hyperactive immune system, then I assume she's at risk for implantation failure, she's at risk for miscarriages, and later for other things later in pregnancy. If I cannot find any evidence for a hyperactive immune system, then in general, I would say that is not my first suspicion. So we do not do these $4,000 or $5,000 immune workups that are done by some people. And again, I do not want to criticize them for doing it. They just have a different look at things. We do a much simpler test. We do not refer them to a rheumatologist or an immunologist unless we discover that they have a disease, which sometimes happens. And we also treat ourselves. So in other words, we do not send them for treatment. Treatment depends on how hyperactive the immune system is. If it is just minimal, then the treatment is minimal. If it is more severe, then we go up in the cannon size.
So what particular tests are you looking at if you're looking for a few tests that you want to identify something?
I tell you what our routine screen is for principally in principle every patient. We look at her CBC and her differential. We look at inflammatory markers, and we use C-reactive protein, SED rate, and IL-6. We look at total immunoglobulin levels. We get an antiphospholipid antibody panel. We look at thyroid function and thyroid antibodies. We get an ANA, obviously, an ANA panel, and that's it. And
natural killer cells?
No.
What are your thoughts on natural?
I'm not a big fan of natural killer cells because the peripheral natural killer cells are very different from the endometrial natural killer cells. So I don't see the logic in looking at peripheral natural killer cells to get a read on the endometrial. There are some people who get endometrial biopsies and do look at endometrial NK cells, and we don't do that, but that I would find acceptable, and that makes sense.
In the treatment side of things, aspirin, Lovenox or heparin, prednisone or other steroids, do you think those have some benefit in limited people, many people, or more?
Again, good question. The short answer is yes. And the answer is short yes, for exactly the reason where we started at the beginning of our conversation today, because it's cheap. It's cheap, and it is generally well tolerated. There is, in other words, no downside, or very little downside. That doesn't mean that I necessarily believe it works. Okay, I believe that aspirin works for certain things. I believe that prednisone works for certain things and for certain patients. I have my doubts whether Lovenox or heparin works or is necessary or makes any big difference, but I still use it in some patients, again, for that reason. because the potential benefit is so much bigger that what's really the downside. The issue becomes different when we go to the bigger cannons. I'm not a big fan of intralipid. I prefer intravenous gamma globulin at the next level for many reasons, but that is already getting again into serious money, and therefore you better be sure that a patient really needs it. And then the last level, all the biologicals now that have come into the market through rheumatology and so forth, we use very sparingly because we are still concerned about the effects on the pregnancy.
Is there any particular test that you would say, they need IVIG? Or do you really look at the clinical situation and the history of failed cycles, do you think?
Yeah, the answer is both. Let me give you an example. If we have given a patient who does not show much on testing, our standard treatment of baby aspirin, Lovenox, and low-dose prednisone, and she had another miscarriage, that's an automatic IVIG. Okay. On the other hand, an automatic IVIG may also be a first-time patient who has a lot of abnormality. She has a positive ANA panel, she has lupus anticoagulant, she has other antiphospholipid antibodies, God knows what else she has. She will also get automatically, even at first try, IVIG. Okay. The biologicals we really use only once IVIG fails. It's kind of the third level of treatment.
Plaquenil? It's a question from Summer.
Plaquenil we use actually quite frequently, but only in patients who have inflammatory markers. So if the patient has a high C-reactive protein or a high IL-6, we will use it. We will also obviously use it if she has lupus or rheumatoid arthritis, meaning an active autoimmune disease with an inflammatory component. Yeah, but remember, if you give your patient Plaquenil, she needs to have an eye exam every 6 months.
If they're going to be staying on it for sure. I mean, I believe the cause of most fertility issues is inflammation. And so some treatment of inflammation is always something we should look at. Things like acupuncture, massage, chiropractic, even nutrition. Where do these fall into your thoughts and ideas in the add-ons?
So amongst those, the one that I believe in the most is nutrition, and particularly an anti-inflammatory diet. I have never studied it. I'm not a nutritionist. I'm myself not on the diets I should probably be on, but I have seen amazing responses in patients with inflammatory problems, including endometriosis. So I have become, I must say, I was a skeptic, but I have become a believer in anti-inflammatory diet. No question about it. No.
We focus on keto, which is anti-inflammatory, and carnivore for some people, some fasting, which I do believe has some benefits, and that might be something I think we're working on and studying and sharing some data on that. But
my significant other will love you.
Okay, we'll talk. You and I will talk more about it. We'll talk more about it. Progesterone and estrogen. Is it an add-on? after a fresh transfer, or is it really just standard, which in our
I don't consider it an add-on. We have been using progesterone estrogen supportive luteal phase since the earliest day of IVF.
Regina Marie, I'm not sure I brought this question up. Are there any particular recommended add-ons for women over 40 or maybe with diminished ovarian function?
We before I say anything, I must point out that I have a potential conflict here, a commercial conflict, because I am a part owner of a company that produces some supplements, including a supplement that is called DHEA, which is a natural hormone that all of our bodies are producing and from which our bodies make testosterone. So I have to say that because we are using in women above age 40 very frequently DHEA, because after age 40, androgens in women decline very quickly. Now, we supplement them usually only if the androgens are low. So in other words, we test them. But since that is usually the case in most women over 40, different degrees, some more, some less, most of our patients over 40 are being supplemented with DHEA. And the reason is that it is now very well established from a whole variety of animal models that good androgen, the ovaries need good androgen levels, paradoxically. We are also supplementing with an antioxidant called CoQ10. And again, this is based not on our work, that is based on based on the work of Bob Casper many years ago in Toronto. There is good evidence that antioxidants may help patients over age 40. So I would say those two things and the baby aspirin is pretty much a standard supplementation at that age.
Ubiquinol?
We prefer ubiquinol to standard CoQ10 because it has a better absorption, but standard CoQ10 is also good. We just give it at higher dosages.
Cool. Let's see. We're going to be putting this on replay for those that want to listen and learn more. So if you miss something, you'll get this probably as a replay tomorrow, and it'll be on for whatever time we can keep it going. Let's see. Shandana BK, what is your take on duostems? And will that help get more blasts or just maybe more cleavage embryos? Do you have any opinions on the duostem world?
You have a very educated following here in your programs. It's another very good question and another very controversial issue, in my opinion. So duostem was developed for young women, mostly diagnosed with breast cancer, who have very little time to freeze a few eggs quickly. And so somebody had the idea, why don't we, after stimulating once and do a retrieval, start stimulating right away again? Maybe we can get a second retrieval in. And it worked. And it shouldn't have surprised that it worked, because we now know that recruitment is a steady process and that follicles are constantly in all stages. Now, as so often is in medicine, and especially in our profession, this idea was picked up and moved into other areas. Bringing me back to the point that it matters in whom you study something, and you cannot automatically move it. But that's exactly what happened here again. So people started doing it, and started reporting, all those wonderful numbers. We get so many more eggs and so many more embryos and so forth. But what they didn't tell was that if you do a double stim, you obviously can't do a transfer. Now that doesn't mean anything in a patient who is going to have cancer surgery or chemo and who just wants to freeze eggs. That doesn't matter. But in the average infertility patient, it completely changes her treatment plan.
Mm-hmm.
You know? And therefore, it is no longer the question only, do you get more eggs and more embryos, but what are the side effects? More cycles, more freezing, more poorer pregnancy rates from that, etc., etc. So in short, we are not fans of dual stim for routine infertility. If you're planning on freezing eggs, if you're planning on freezing embryos, different story. But to change your treatment plan, and by doing so, having to freeze rather than where you would do a fresh cycle, in my opinion, doesn't make sense.
Can we go? We're get a little over, starting over an hour. If you have a little more time to keep going, we're getting some good questions here, Dr. Gleicher. Zymot, recommended add-on, yes or no? Is there any particular test you think that should be done to help direct us to any of these things?
I don't even know what Zymot is. What is Zymot?
Well, Zymot is a sperm separation, like a swim up that has been suggested to separate out the DNA fragmented or damaged sperm.
Yeah. So the fact that I don't recognize the name tells you already that we're not using it, because again, we are trying to keep things as simple as possible. Okay? If a guy has a normal sperm picture, hallelujah. If the guy has an abnormal sperm picture, ICSI, and ICSI will take care of the problem, period. End of story.
So thin linings are difficult to thicken linings. Viagra, and this may be things like Neupogen, PRP, even HCG washes. I hear all these things. We do some of them. What are your thoughts on any of these?
Yeah, we have a hierarchy, obviously. We're starting with the routine endometrial support. If that doesn't work, we go up in estrogen support and add Viagra. If that doesn't work, we do a uterine perfusion with GCSF, which we were the first ones to use and which works very well. Excuse me. Usually within 48 hours, you get a nice response. And we recently, and this is very recent, I would say the last year only, if we don't get to where we want to be with GCSF, we will use a PRP wash.
Mm-hmm.
And again, I don't have enough data to speak about it yet, but in some cases we have seen an effect. But it's a hierarchical progression.
So let's see. Summer Albany has another question about probiotics in issues and concerns with uterine vaginal microbiome.
Yeah, I know very little about that. I have been following the literature. Most of the literature has come out of Spain, and I think that's important to note because not everything that has come out of Spain has proven to work. But I'm also following the microbiome literature in general, and that is really fascinating. And our gut microbiome is us. It really controls our lives, and we didn't even know that we have it. It is so important. And therefore, I would not be surprised if the vaginal microbiome also has a function. The reports that there is also an endometrial microbiome have actually been mostly now refuted and have been attributed to contamination during sampling.
Mm-hmm.
There seems to be a vaginal microbiome, and there is some interesting data out there that suggests that the vaginal microbiome can be related to certain gynecological conditions. I'm not yet at the point where I would start doing it and testing for it for diagnostic purposes, but I wouldn't be surprised if that would become something that we will get more involved in.
Well, I think it's an unwanted hitchhiker personally.
Okay.
And if you look at James Henry Salisbury's work, Salisbury steak from the 1800s, he was an Albany Med graduate who was a chemist and a microscopist. And he showed that in his men in the Civil War, bacteria and yeast were proliferating in the gut and then went up through their esophagus and into their lungs. And my bet is the same thing happens when it goes out the rectum and it contaminates the vagina, and it's probably more harmful than it is good. It's kind of interesting information, but we don't always have straight.
Again, I don't know enough about it at this point, and but I'm following the literature because I think what has come out in how important our gut microbiome is for our brains and for stuff like response to chemotherapy for cancer patients. I mean, it's mind-blowing. It's really mind-blowing. So I have a lot of respect for what is being discovered in that arena.
It is all quite interesting and amazing. Do you use any particular doses of IVIG when you're treating patients? I know some people use a standard 10 to 20 grams. Some people do 400 to 600 milligrams per kilogram.
Yeah. So we use, our standard dosage is between 25 and 40 grams, unless it is really a 400-pound lady, then we go also higher, or unless the patient has an autoimmune disease. But once we go to the next dose, which is 60 milligrams, we give it in 2 days, on two sequential days, twice 30. So we never give more than 40 in one sitting.
Yeah. Well, let's do one more question here. And fresh versus freeze-all cycles. What's Dr. Gleicher's opinion?
That is also one of those new add-ons that I simply don't understand. I don't think you need to be a scientist. You don't need to be a doctor even to understand that fresh is always better than frozen. If there are no other reason, there's one reason. And again, for that, you don't need to be a scientist or a physician or whatever. And that reason is that once you freeze something, you can never be sure that it thaws out well and will still be alive. Okay? So there is a loss factor always.
Mm-hmm. Mm-hmm.
And why lose something if you don't get anything in return? And so our principle here has always been fresh is better. We freeze if we have to, but we don't freeze voluntarily. If there's a good reason, you freeze. And we have gotten much better in freezing, much, much better. But still, the old dictum holds, fresh is better than frozen.
Any other add-ons that you might want to touch on that you think we should just bring up as a topic, or we could save to next time?
Well, I think we got to all the main players, especially with the last question, because freezing again also has become enormously popular amongst many of our colleagues. But you have to again wonder about the motivation for it. It simply doesn't make any sense, and it's not only logical. There are now also lots of studies that show that the alleged benefits do not exist. It's actually exactly the opposite.
Dr. Gleicher, thank you so much for sharing with us again. And I'm hopeful we can do this on a regular basis because so many people have great questions that need to be answered. And
Anytime.
We will see you very soon. Thank you so much for this evening.
My pleasure.
And I hope to come down and visit you very soon.
Always a pleasure.
All right. Thank you, everyone. And thanks for sharing today. Appreciate everyone.